That brings us to our next speaker, who probably needs no introduction, but I will provide a short one anyway. Professor Tim Cook, we're very pleased to have you. Thank you so much for joining us. You are on screen, so no, you were. Tim is an intensive care physician and anaesthetist at the Royal University Hospital in Bath. Is an honorary professor at Bristol University, is the lead author in at least 5 national airway projects in the United Kingdom, including the well-known NAT4, which has been mentioned a number of times today, and more recently received an appointment as an officer of the Order of the British Empire for his work in COVID-19 clinician safety in the UK. Thank you very much for joining us, Tim.
Thanks, Jonathan. To be clear, the OBE is historical. It was in the Elizabethan era. So, so thanks very much. It's a pleasure to be at SAS. I've now recorded this talk 3 times. I hate recording talks, so this isn't recorded. I'll have a go at it. So I'm going to try and bring some of those pieces of information that the last 3 speakers have talked about, and talk about airways, aerosols, and healthcare worker safety in the pandemic. It is somewhat historical, but actually it's relevant for where we are now. I don't have any conflicts. I describe myself as neither a dropletier or an aerosoldier. I don't think there should be many dropletiers around anymore. But I would like to pay tribute, firstly, to the 2 groups that I've worked with, and I feel peripheral to the work done by these groups, but particularly the aerator group in Bristol, particularly Andy's work, and the Sydney team, Nick Wilson, Ewan Tovey and colleagues. And also to acknowledge the work done by Dr. McCain and colleagues in Melbourne. I think the collaboration and discussions with the aerator group have been very important for this. What is noticeable about all the groups that have done good work in this area is that they tend to bring together both clinical expertise, senior clinicians and clinical researchers, with those who work in the field of aerosol science in universities. And I think many of the studies where that's not happened have been the lesser. Take ourselves back to spring 2020. Everything's transmitted by fomites. Wash your hands, wash your hands, wash your hands, sing whatever it is, happy birthday. And droplet transmission occurring within 1 metre within hospitals, or 2 metres outside hospitals. That's what it was in the UK, go figure. And no airborne spread unless there was an aerosol generating procedure going on. And so we had this risk model that if it was very procedure directed, that if you were more than 1 metre or 2 metres outside hospital and there was no AGP taking place, there was no risk of transmission of infection to anybody close by. And if you were a health worker doing an AGP, there was a significant risk of infection and harm, remember, pre-vaccination. So we had this long list of anaesthetic and respiratory support AGPs, which we were left. And I'm going to obviously focus most on UK work, but it'll often be relevant to you guys as well. 2021, December 2021, WHO aligned with CDC in saying that anybody working close to those suspected or known to have SARS-CoV-2 should be wearing a high-quality RPE, respiratory protective equipment. Not all countries have applied that, and certainly they haven't in the UK. To go back to the basics, just to be clear, aerosols are produced by various regions in the respiratory tract. The higher up, of course, they are, the lower down, probably the most important. So lower down, bronchial and small airway aerosols are produced by small airways collapsing and expanding and breaking up fluid films that produce aerosols of the size of about 5 microns, which are respirable and probably, with the later viruses, carry the most virus. The rule of cubes would make us think that a piece of snot of half a centimetre in diameter might contain 125 billion viruses. It doesn't, in fact, work like that. As these aerosols are produced, they dry very quickly in the air, and these large aerosols tend to be mostly supporting material and fluid and very little virus. And the smaller ones are more densely packed with virus and therefore potentially more risky. So we started with this false paradigm, this dichotomy between droplets and aerosols, whether you choose 5 or 10 microns. In reality, particles as much as 100 microns can behave as aerosols in a respiratory plume. And I think this is really important, that as you get within about 1.8 meters, so as you see on the two graphs, as you get within about 1.8 meters, then the effect of ventilation, so the risk increases the closer you get to the other individual. As we share other individuals' airspace, we share their exhaled air and we share their viral load. And once you get within less than 1.5 meters, there's very little protection from external ventilation. And it's all about what's happening close by, which of course is where respiratory protection comes in. So while all these hierarchy of controls, the vaccination, screening patients, avoiding infected patients, are much more important than PPE from a general perspective, once you're up close and dirty with the patient, then we are very reliant on PPE, RPE. And so this is illustrative. Depending on what you and the person you're close to, be it a patient or someone serving you in the supermarket, depending on what you're wearing, so it's all about probability. There isn't a risk dose, but it's all about probability. And so if X is the time that you can spend with a low or high probability of getting infected from an individual, if you're both wearing nothing, if you're both wearing fit tested RPE, then it's down to about 1% of X, 100th of the risk. And you can spend roughly 100 times the length of time with that same risk. Have we implemented the WHO CDC guidance in the UK? No, we haven't. So for a short period of time in April, it was stated that everybody should follow that WHO guidance. And then 4 weeks later, it was retracted. What we have done is revise the AGP list. And this is in large part due to a rapid review strongly supported by the members of the aerator group and very strongly leaning on Andy Shrimpton's work, led by him, I would say, done by him. And so these in England, not in the whole of the UK, but in England, these anaesthetic and respiratory support procedures, including BiPAP and high flow nasal oxygen, are no longer considered AGP. And that's quite correct based on the science. The few that remain, bronchoscopy, endoscopy, that is supported by evidence. They produce large amounts of aerosols. Those other factors, so some surgical procedures remain there because of a lack of evidence rather than evidence of actually being AGPs. So what happened on the ground? What has happened on the ground? What is the risk? ITU. So based on what happened in SARS, we were particularly concerned about ITU. It was a time of great fear and of great uncertainty in that first surge. So this is an indicative study that's called the SAFER study. It's from University College Hospitals in London. At that time, the prevalence of infection in London was about 15%, 1 in 6 individuals. And they looked at about 400 frontline healthcare workers and tracked them over a period of 4 weeks at the peak of the surge for whether they became PCR positive or if they were seropositive. And about a fifth of individuals became PCR positive and almost half became seropositive, indicating a current or historical infection. So about 3-fold higher than the local population. Amongst the group that was lowest risk was intensive care doctors. And actually, if you look at a whole series of these studies taken from different areas of very significant size, up to 10,000 healthcare workers, and very large populations in the REACT study and the ONS Office for National Statistics studies, they're consistent in that the risk of infection of healthcare workers in the first surge roughly 3- to 4-fold higher than the population in the community. But within healthcare workers, who gets infected? So this was a study from Oxford, 10,000 staff tracked over the peak of the pandemic. And you'll see that it's those people who were lower in the hierarchy, those people who are close to the patient. So porters, domestics, AHPs, far more likely to get infected than senior doctors and senior nurses, and certainly than backroom administrative staff who don't have any increased risk compared to the normal population. So here we see that in the red box, we can see that at the bottom, you've got the frequency of COVID infection, and in the ward, patients with COVID, and on the y-axis, you've got the frequency of infections of staff. So in these, what well, within the red box, can't remember what the colour is, you've got high rates of patient infection, but low rates of healthcare worker infection. Whereas in the purple and the darkish green, you've got relatively low rates of patient infection, but high rates of staff infection, because RPE and protective care works on ITU and is inadequate on the wards. Other studies similarly from Birmingham, again, fourfold higher risk of infection of healthcare staff compared to the community. And who gets it? Again, housekeepers, porters, people working in acute medicine, not those working in intensive care. In terms of admissions, this excellent study by Shah, looking at the entire Scottish population, showed that frontline healthcare workers were at twice the risk of admission. Once admitted, a reduced risk of mortality if you were admitted compared to the population, probably because of underlying good health amongst healthcare workers. But also healthcare workers, family, twice the risk of admission, ICU staff, low risk. Who dies? In the pandemic, this is one excerpt from work we did looking at the available data, and there was particular concerns about surgery, particularly because a young ENT surgeon died early in the pandemic in the UK, and it was very concerning to all involved. But actually, surgeons are probably no greater risk than other healthcare workers, perhaps less. And within the surgeons who did die, there was no specific particular specialty that was overrepresented. What is noticeable is the absence of any both physicians or indeed other staff in anaesthesia or ITU. So Simon Lenane, who's a GP from Shropshire, who I met online, and I looked at the relative risk of anaesthetist intensivists compared to others. And what we looked at that time, there had been one death of an anaesthetist who almost certainly acquired the disease at home. And we compared, using nationally available data, the relative risk of anaesthetists and intensivists dying compared to other groups of doctors, be they hospital doctors, patient-facing doctors, the NHS workforce, or indeed the general population. And however you dice it up, we're at low risk. So a quarter to a third of the expected risk. So it's clear that frontline healthcare workers, and only frontline healthcare workers, increased risk of infection, hospitalization, and probably of death, anaesthetists, intensivists, and those who work in those environments at lower risk. What are the reasons? I think all these are potential reasons. We have better PPE. We have better behaviours. We know how to segregate ourselves, whether it be in theatre or avoiding infection in ITU. Look at the behaviour on the wards. It's often not what it should be. The infection probably burns out before most patients get to ITU. We have better ventilation, as Forbes has said. Most of the AGPs aren't AGPs, and probably our exposures are intermittent when we go and do procedures, whereas on the wards, you may be exposed to patients for a long period of time in poorly ventilated rooms. Again, who dies? Well, many of the papers in the UK showed pictures of health and social care workers who died early in the pandemic, whose deaths may or may not have been related to their workplace, but almost certainly were, in fact, or some of them. And what was noticeable was the absence of white images, white faces in these pictures, and the predominance of those from non-white ethnicities. So non-white ethnic individuals make up about 20% of healthcare workers in the UK, but accounted for 63% of deaths in those first 6 months. And whichever specialty you look at, the grey bars representing the percentage of deaths that were not non-white ethnics is dramatically higher than in the population. So, for instance, amongst doctors, 94% of those who died were of non-white ethnicity, and 44% of doctors are of non-white ethnicity. Particularly also of note, first-year migrants, and I think a lot of this is social geography. Can you do anything? Well, it's very clear in the lab that FFP, that respiratory protective equipment, is effective in filtering, but does that have any effect on the ground? The flu studies, a lot of them done by a chap called McIntyre, have found it difficult to show differences, probably because compliance is not very good around flu, but actually it's probably better around SARS-CoV-2. And within hospitals, there were two epidemics going on. There was an epidemic of infecting healthcare workers, an epidemic of infecting patients, with 1 in 5 of all the patients with COVID in the UK at one point having acquired their infection there, and that probably being a significant underestimate. So in Cambridge, they introduced FFP3 masks throughout the hospital, not just in intensive care, against the guidance that was prevailing at the time in the UK. So what we hear is that have the rate of infection at the latter end of 2020 on green wards where they weren't looking after COVID patients, and red wards where they are looking after COVID patients. In the green wards, it tended to increase as the population risk increased. And in the red wards, there was little epidemics, outbreaks of COVID infection. Towards the end of 2020, just as the second surge was increasing, the Delta surge, they introduced these FFP3 masks and saw a dramatic reduction in these epidemics occurring on the ward amongst healthcare staff. And they estimated a 47-fold decrease in hospital-acquired healthcare staff infections. And this work from Tom Lawton, from Bradford and colleagues, looked at the effect of those hospitals. So here we have in red those hospitals who followed national guidance and restricted RPE to high quality RPE to intensive care and theatres and AGPs, and in blue those hospitals that expanded it to the wards. And both in Alpha and Delta, the rate of hospital-acquired infection of patients was lower in those patients who had the more liberal use, the more appropriate use of RPE. So to summarise, most of the designated AGPs, which are probably still designated AGPs where you work, are not AGPs. Notably, upper GI endoscopy with coughing and awake tracheal intubation, which are very cough generating, produce even higher brief episodes of aerosol generation than does coughing. So we need to move on from this risk model to something that's more complicated but more appropriate. So does the patient actually pose a risk? Are they infected? What's the likelihood of being infected? Have they been vaccinated? What's the timing of their illness? What's the variant they carry, and how risky is that? What's the duration and contact and our proximity? And de-emphasized the nature of the procedure. Only certain procedures increase risk. And then mitigation. We've got environment mitigation from ventilation, UV elimination. We've got PPE, RPE, and we've got the impact of vaccination, which partially reduces the risk of infection. And then if transmission does occur, will it affect the healthcare worker? So we have both vaccination, dramatically reducing the risk of significant illness, but also the healthcare worker's susceptibility. And the four factors that are most associated with risk of harm to the healthcare worker are age, and sex. So being male increases your risk of harm or death about 50% compared to female, and every year of age increases your risk of death from SARS-CoV-2 by about 12% every year. So we need this hierarchy of controls. PPE is not the most important, but once you're, as I say, up close and dirty with the patient, then PPE is what we rely on, specifically RPE. Should we be changing our technique? Should we be expanding the use of RPE? Yes. So where are we at? Now, I think we need to implement the revised AGP list. We need to follow the science. We need to expand the use of RPE to the right place. I know that's better in Australasia than it is in the UK. We need to risk assess logically based on our knowledge rather than some simplistic and outmoded tools. And we need to get back to work safely for everybody. And we need to be prepared for the next one. Now, do I mean the next variant or do I mean the next epidemic? I'm not sure, but we must learn from where we've got to. To finally close with this study, this is a really brilliant study from Don Milton's group, where across the pandemic, they've looked at different viruses and looked at infected patients and the amount of virus that they exhale that's in their nose and whether fomites detect grow virus. So, as I say, looked at it across variants. Much of the work where we look at individuals and say, we extrapolate from how much they cough. Most viruses, you cough up to 12 times an hour if you're infected. Some people coughed 140 times per hour in this. The virus was reliably grown from everywhere except fomites. So let's get rid of fomites, let's focus on aerosols. And in these patients who were Omicron vaccinated and then infected, so they had a breakthrough infection, they were very heavy shedders of Omicron, 1,000-fold more compared to Delta. But importantly, that rate of shedding from in exhaled breath is about 100-fold less than flu. So there's still a potential 2-fold 100-fold potential increase for Omicron in terms of its risk of infection. As emphasized before, most of the virus is in the small aerosols, those less than 5 microns, probably because they're generated from the bronchi, and Omicron, of course, has a much greater propensity to grow in the respiratory airways and the upper respiratory tract compared to its previous variants, which grew predominantly in the lung tissue. This is all consistent with an explanation for increased transmission, with Omicron having about a 12-fold higher R0 than the Wuhan variant. And it's consistent with selection, natural selection of clades with increased transmission. This will continue, and it's not over. Thank you very much.
Thanks so much, Tim. We've got a couple of minutes for questions, which is excellent. I'm sure that there are some. Please come up to the microphones. I suspect that these presentations will have raised a couple of questions or comments or concerns.
So I'm going to switch to probably my phone, as I now drive to the airport.
While we're waiting, Forbes, I'd be interested, could you tell us, why do you think your hood is in use in Australia in the local Oceania region, but not so much elsewhere in the world?
Yeah, I suppose it's where you, develop something and where there's knowledge of it. I think that's a very large question that would broach into the whole area of how do you develop something, and then how do people take it on, and how do you, either convince or show that it works, and it's a big thing. And I think that we have certainly talked to doctors in quite a few other countries about the hood. The uptake, yes, has been quite limited. I think part of that is simply because of where you come from, in a way. I think part of it is just that what they're used to. And it's not part of PPE. It's not like we're not trying to sell an N95 mask like the chap in front of me, which is absolutely part of standard care. This is not part of standard therapy. So I think that's a really major part. It's an innovation. I think the other thing that is difficult in this area is that this is not a randomised controlled trial that we've done, because that would be, firstly, very difficult and impossible to do now with the numbers of people. But it also is something that would be incredibly expensive if you were able to do it at the time. So, yeah, it's interesting times. We're still very happy that it's used in about 150 hospitals in Australia and New Zealand, but that's another long story. Thank you.
Questions from the audience, or are there any popping up on Twitter? Tim, are you still able to take questions in your drive to the airport?
Certainly am.
Is this responsible of me to even suggest the idea?
I'm not in the car yet.
Oh, excellent. Yes, thank you.
So we've seen the AGP list from the UK, and it has two things on it now. Wake intubation and gastroscopy with an induced cough because of that. So should we rename them cough-generating procedures, or should we just scrap the concept entirely?
Tim, did you get the audio for that?
Yeah, I did. Early on in the pandemic, there was a brief article in the Lancet Respiratory written by Aerator, the Aerator group, including Andy Shipton, trying to de-emphasise the procedure and emphasise people as aerosol generators. Many people have done the same thing, and I think that's where we should go. To emphasise, although I've said how many things have been removed from the AGP list, it isn't just those two things that remain. There are a few other surgical and post-mortem procedures that remain on the list, rightly or wrong. I completely agree that coughing is key. So whether it be extubation with cough, whether it be awake tracheal intubation, it isn't a cough, it is that index. But one of the things that is important, and I think Nick Wilson and Ewan Toby's work, one of the things that we teased out of that, we emphasise these aerosol generating procedures such as cough, but they're very transient. The cough lasts about 12 seconds. If someone's dyspneic, which is equivalent to exercising, in terms of how much aerosol they generate. If you integrate the amount of aerosol generated relating to dyspnea over a period of an hour, or someone breathing relaxed but coughing 12 times an hour, then it's the dyspneic patients who generate several-fold, many-fold, hundreds-fold higher amounts of aerosol. And that's why the wards are dangerous, rather than necessarily being close to coughing patients unless you're in very close proximity. It's also why nightclubs, exercise and shouting are dangerous, and why gyms are dangerous. So I think we shouldn't just focus on cough. It is more than cough. It's about, and I think if those who haven't read Nick Wilson and Ewan Toby's paper about respiratory, the exertional respiratory activity and the amount of aerosol generated and the subsequent science letter, I think they're really worth reading.
Yeah, I'd sort of add that the other thing, Tim, is that, for several days before you know you have COVID, you're asymptomatic, but you're infecting other people. So the mere fact that you're breathing and talking, if you're in close enough proximity to someone, will infect someone else. And that's another part to the story there.
We still have a minute. I can ask this panel questions all day. I won't, not all day, but I will keep asking questions if no one else is brave enough to stand up. I'd be interested to do a social experiment of the people in the room. Of the people in the room, based on what's been presented, who, if they had to intubate a patient with COVID-19 this evening, would have some sort of visceral or emotional response to doing it only in an N95 mask without the additional PPE we've been wearing for the last 2 years? Pop your hand up if you would have some sort of emotional response to that. Is happiness, the question was, is happiness an emotional response? I suppose it is. It wasn't the one I was thinking of. A few hands did go up. I'm curious, and I don't know who to direct the question to, maybe Forbes, because he's sitting right next to me in the first instance, but what role does emotion have in how we might implement PPE policy? Maybe a quick comment from each panel member.
Daniel Kahneman, System 1 and 2, thinking fast and slow. So it's got enormously important, but I think that what we have to do, and I think that's the great work of Andy Shrimpton and Tim Cook and the rest, the aerator group as well as others, in trying to, we have a much more solid foundation of our science now than what we did 2 years ago. There's more to be done, but it's really exciting what's been done. And I think that's really showing that it's not really about intubation, it's not really about procedures, it's about proximity and duration and whether you've been vaccinated and how old you are and whether you're immunocompromised, and all those are more complex things that are just a bit more difficult to quantify very quickly. But I'd say that I've intubated lots of people, sadly, with COVID-19, and I think all along it made sense, a lot of the aerator work, because the patient was paralysed when I was doing it. They weren't coughing, they weren't doing anything, they were paralysed. But that's my response.
I would say the emotional response is going to take a bit of time to get over. Everybody's pretty traumatised by it, so to accept the new data, even though it's getting increasingly more stronger, is going to take a little bit of time, I think, for people to take that step. And I think the main thing is trying to spread that data around and try and have more groups agreeing to it as well. So what I found in Australia is that every hospital seems to have a different list of aerosol generating procedures, whether it's public, private. So having a group that's going to have a united list, I think, will help as well.
Andy, you still on the line? Do you have any thoughts on that question?
Yeah, I agree with both speakers. And essentially, at the very start of the pandemic, what it was like in Australia, but certainly in the UK, it was drilled into us that this is the most dangerous thing you can do. You are at the absolute forefront of, everyone, people that you work with are going to drop down dead. It's going to be terrible. And to kind of wind back from that situation is going to take a bit of time. And some people have wound back quickly, but for some people it will take a lot longer, and that's understandable. And I think there needs to be support for kind of the whole range of people who, feel kind of both they want to get rid of the PPE to the people who are very anxious. And I think it's going to take time.
And Tim, I suppose it goes to the heart of whether we can implement what you're suggesting. Do you have any comments on that question? If you're still with us, Professor Cook. He might be in a taxi. We should all be so lucky. Well, I think that takes us to the end of the time for our session. I would like to sincerely thank all of our panellists, including Tim in his absence. So if I can ask you to put your hands together, thank you very much.